Okay. Welcome everyone. So welcome to the first junior doctor teaching organized by UKRST. I'm Shwed, one of the admin members of UKRST. So as you're probably aware already that we are a platform and a group of aspirant radiologists who are helping our newcomers to get into radiology. And this is part of this is the first video and first teaching part of a series that we are planning to conduct over coming weeks and months. And this time we're accompanied by Nimrat Sheikh, who is a junior doctor and part of our committee team, and she's conducting this teaching. Uh, and we have other team members from UKRST. So I'll start introductions one by one. So Dalia, can you please introduce yourself?
Hi everyone, thank you for joining this webinar today. My name is Dalia. I'm currently a GP trainee. I'm one of the UKRST committee members. I hope you'll find this teaching useful. Thank you, Shway. Dav, do you want to go next?
Thank you.
Yeah, sure. My name is
Sadaf.
Sadaf. Yeah, sure. My name is Sadaf. I'm one of the teaching coordinators here in UKRST, and I work as a clinical fellow in urology. Maggie.
Perfect.
Hi everyone, thanks for coming. Yeah, same here. I'm a teaching coordinator for UKRST, and I've just started ST1 training in radiology in Kent.
Namras.
Hi, my name is Nimris. I'm one of the social media managers for UKRST. I'm currently in F3 in Royal Stoke, and I will be presenting today.
Excellent. I'm Shoaib, as I've introduced myself. I am currently in ST3 Radiology Registrars in Merseyside, and I will be conducting and moderating this along with my team. A few things to note before we go ahead and make a start. So please make sure you keep your cameras and microphones off during this. If you have any questions, you're more than welcome to put them in the chat. We will be constantly monitoring chat and trying to answer your questions if we can, or else we'll take all the questions towards the end. At the end of this teaching session, we will be introducing or sharing a teaching feedback link to you guys. Please take a few moments of your precious time and fill it out, because that's very beneficial for our fellow members here. And it's not just that, it's also a motivational factor for us to keep continuing and improving on our work. With regards to UKRST, many of you would be members of the WhatsApp group. So if you're applying for ST1 or ST3 training course in the coming years, you're more than welcome to be part of the WhatsApp group. This year, we have introduced our UKRST website. We will shortly share the link if you're not already aware of it. And you can go on that, and we are trying to build a resource which you can use throughout, not just for the application, but alongside your training pathway as well. Our aim is just to help you guys excel in the career and primarily just enter radiology. So I'll wait for a few more minutes. I can see we have around 12 participants. So I'll wait for 2 more minutes, and then we'll make a start, and people can then keep joining in, just so that I know you all have taken time out of your busy routines. So I'll turn my microphone off. If you have any questions that you want to ask before this, you are welcome to write them in the chat, and we'll try to answer that. And the recording is in place. We will upload this on our channel. Please make sure you follow our social media pages and platforms to keep updated with our upcoming webinars as well. And we have a YouTube channel, so this recording will be uploaded where you can even watch afterwards. Okay, so it's 7:05. So I'll hand over to Namris, and I'll turn my microphone and video off, and I ask my fellow team members to do the same as well. And I'll hand over to you, Namris, if you can start sharing.
Can everyone see this?
Yes, I can. I hope everyone else is. But if anyone is having issues, please drop a message in the chat and we'll try to help you out as much as we can.
Thank you. So this is the first webinar in our Bitesize radiology teaching. This specific webinar is on identifying medical tubes on chest x-rays. And I hope you enjoy the webinar. So starting off with the learning objectives. So firstly, to establish the importance of correctly identifying commonly encountered medical lines and tubes in a chest x-ray. 2, identify normal anatomical landmarks on a chest x-ray. And 3, differentiate between correct and incorrect positioning on common medical tubes on chest x-rays. So why is it important for us to correctly identify medical tubes on x-rays? So firstly, to ensure that we have correct positioning of our tubes. And secondly, to avoid any complications such as pneumothorax, lung collapse, looped tubes, aspiration, etc. So what are some anatomical landmarks on chest x-rays? It is important to note that we're only going to discuss the main anatomical landmarks related to lines. However, there's a lot more anatomical landmarks that you'll need to know when reviewing or trying to identify chest x-rays. So starting off with the trachea. So here's the trachea. The trachea bifurcates into the right main bronchus and the left main bronchus. Where the right and left main bronchus bifurcates is called the carina. Here is the aortic knuckle, and here is the diaphragm. It is also important to note that it's difficult to see the esophagus on a chest x-ray. However, it's usually on the left of the trachea and medially to the aortic knuckle. So moving on, here's another diagram with important structures that you should know as well. So here is the SVC, and here is the cavo-atrial junction. This is the superior vena cava, the cavo-atrial junction. This is the right atrium. And here is the carina, like you can see here, and here's the trachea. And here, obviously, some vertebral bodies. Now, moving on to our first tube, nasogastric tubes. So, to confirm gastric position of the nasogastric tube, you should always ask yourself the following questions. So, 1, does the tube path follow the esophagus or avoid the contours of the bronchi? So as you can see here, it does. Okay, so next, moving on. So does the tube clearly bisect the carina of the bronchi? So here's the carina, and yes, it does clearly bisect the carina. Okay, does it cross the diaphragm in the midline? It does here, as you can see here. Okay, and is the tip clearly visible below the left hemidiaphragm? And you can see that here. Okay, so proceed to feed only if all of the criteria are met. Otherwise, obviously, if you're in doubt, repeat the x-ray or call senior for help. The next thing here is you can see that the NG tube is supposed to be at least 10 centimeters below the diaphragm. So if any doubt, again, call a senior. So complications of NG tube placement. So the NG tube can go into the right main bronchus, which can lead to aspiration. And in this case, the tube will need to be removed and replaced again. And then so the next one is the NG tube can be looped back on itself. And again, in this case, the NG tube will need to be removed and put back in again. The third complication is that NG tube can be pushed too far into the duodenum. In this case, the NG tube will need to be pulled out slightly. And when it's pulled out, then you'll need to aspirate some gastric fluid and then check the pH of that gastric fluid to make sure it's in the correct position. And then in some cases, the NG tube might still be in the esophagus, so it's not reaching the stomach. And in that case, you have to push it in further. Moving on to endotracheal tubes. So the correct positioning of an ET tube. So the ET tube should be in the trachea, okay, and it should be about 5 to 7 centimeters above the carina. So this is the carina, and it should be about 5 to 7 centimeters above the carina. The complications of ET tube insertion. So the ET tube might be pushed too far into the right or left main bronchus. It's more than likely that it will go into the right main bronchus, as that's more vertical. And if this happens, that would lead to ventilation of one lung and collapse of the other lung. So if this does happen, so if it is placed incorrectly, it should be repositioned by a trained individual. That's really important. Sorry, just going back here. So if the carina is not visible, we can use vertebrae to count out where the ET tube should be. However, this is not very reliable, but usually the carina would be between the 5th and the 7th vertebrae. Now moving on to PICC lines. So when you trace the line of a PICC line in the arm towards the axilla, then follow the line under the clavicle and then towards the SVC. And then make sure it's going down towards the heart. Make sure it doesn't go up towards the head, because obviously we want it to get into the cavo-atrial junction. So just make sure it goes down and not up. And then the tip of the PICC line should be in the cavo-atrial junction. Now, some complications of PICC line insertion. So that can be hemorrhage, arrhythmia, arterial puncture, allergic reaction, infection, extravasation, pneumothorax, blood clots, and hemothorax. If the tube is placed incorrectly, again, it should be repositioned by a trained individual. Now we've come to an interactive session, and if you guys can all use the QR code, and we can start this. So if you just want to all log in to this. Is it working? And I'll tell you what to do once. Is it working? Yeah, perfect.
Yes,
Thank you.
It's working. Yeah.
Perfect. Thank you so much. So, basic rules. So I'll basically put up a chest X-ray, and I'll need you to answer 2 of the following questions. So as you probably see that it says what line is shown first, what line is shown, and then the next question that you'll see is the line correct or incorrect? So if you want to answer those questions while I post them, I'll show, and then I'll go through each answer. So this is the first one here. Take your time. I'll give you about a minute. Oh, sorry.
Namris, some of the fellows have mentioned in the chat they're unable to connect using the QR code. Are you please able to share the URL in the chat?
Yes, I can. Give me a second.
Thank you.
No problem. Oops.
No, it's okay. I've shared it.
Thank you. So I'll give you an extra minute there. You guys can see. Yeah, I can get the QR code up again if you'd like. Okay.
That's okay. We have shared the link.
Thank you. Sorry. Yeah, so should we go to the answers then? And maybe next question, go to the next question as well to see if the line is correct or incorrect. Yeah, perfect. Thank you very much. So the correct answer is PICC line, and it's in the incorrect position, and you can see it's coiled here. Okay, perfect. Next question.
Hey, should we
So
go
the next
answers? Yeah. Eight.
So the next question, this answer is NG tubes, and it's in the incorrect position. So here you can see the NG tube is in the right lung, and it's important to note that you can't see any pneumothorax or any pneumonia in this lung here. Next question. Okay, so we'll move on to the answers now. So the answer of this is an ET tube, okay? And it's in an incorrect position because you can see the carina is here. So it's gone into the right main bronchus, leading to collapse in the left lung here, okay? Next question. Okay, so I'll show you the answer now. And this is an NG tube, and it's in the correct position, okay? And as you can see here, it's going down the carina, it's going in past the diaphragm and past the stomach. So next question. So I'll go to the answers, but let me just say that 4 people have picked NG tube and 1 person has picked ET tube, and 2 people have said this is the correct position, and 4 people have said this is the incorrect position. And so the answer is NG tube, and it's in the incorrect position. This is a tricky one because it's looped back on itself. So it's quite a tricky one. Next question. So for this one, the answer is PICC line, and you can see that it's in the correct position. Okay, next question. I think this might be the last one if I'm correct. Okay, so actually, I think everyone's got this right. So this shows a PICC line, and again, yes, it's in the incorrect position. And why? Because it's gone into the internal jugular vein. Okay. So that's everything from me. Does anyone have any questions? If you have any questions, just put them in the chat.
Thank you, Namras. We'll be monitoring chat as well. I hope everyone enjoyed this. I haven't received any questions so far. We'll wait for a few more seconds, a few minutes, to see if anyone is typing and we have any questions coming up. Meanwhile, Namras, can you go back to the slide where the ET tube is misplaced? I'll just highlight one very brief teaching point, which some of you might already know.
This one?
Yes, that's the one. Just go one slide further back where it's just the
Sorry,
X-ray.
yes, of course.
Yeah, excellent. So one thing that I want to highlight, I think numbers. I think this X-ray is a giveaway because you can see the ET tube curving to the left and then going towards the right main bronchus. Sometimes when you see whiteout in hemithorax, there is a number of differentials for it. But here, the one thing that we want to look for, what we want to say, it's a collapse. A very large pleural effusion can also give it, but in that case, you see the mediastinal shift to the opposite side. Here, the mediastinum is shifted to the left, and you can probably see the upper airways here coming in the middle of the mediastinum, and maybe some retrograde aeration of the left main bronchus, but the whole lung is collapsed and you can't see the heart borders. So just a brief thing, because the reason why I've highlighted this is it's important to immediately highlight it to the clinicians. And for many of you, you might be the first clinician, especially if you're working in intensive care. Usually they are very good at picking these things up. So this immediately needs to be corrected. And numbers, we have one question. So Nehal Muhammad has asked what to look for in the chest X-ray after permanent pacemaker insertion. Are you okay to answer that, Nicholas? Or do you want me to take it? Okay, just give me 1 sec. I think ask to unmute.
Sorry, thank you. Can you answer that question for me? Sorry.
Okay. So the thing is, with permanent pacemakers, usually you have to see whether it's a single lead, it's a double lead, what sort of pacemaker it is. One of the key immediate complications that we want to exclude is to make sure there is no pneumothorax, because when they access the subclavian artery, one of the early complications is pneumothorax, which we want to rule out. That's why they do immediate post-insertion chest X-ray. The other things to look for is the placement of the wires. It is a little beyond the scope of this teaching, but depending on what sort of pacemaker is it, if it's an ICD or if it's just a pacemaker, if it's a single chamber, dual chamber, or three-chamber pacemaker, you want to make sure that the leads are in the right chambers. Again, the orientation is different. It's hard for me to comment exactly how to tell which lead is going into which, but usually it's a bi-chamber pacemaker where the leads are placed in the right atrium and the right ventricle. And you want to make sure the lead is not broken off, it's not misplaced. And the other thing is also, which we check in, it's I don't know if it's a misnomer or if it's just a colloquial term, it's called regular syndrome, where people who have pacemakers inserted, they just keep wriggling and the pacemaker displaces and just moves beyond the margin where it's supposed to be. So these are the things that you want to check in a post pacemaker insertion chest X-ray. Another question that we have is, how long does it take for a lung to collapse if the ETT is inserted into the other? So I think I don't know if Numerous, you okay? Or do you know, or you want me to again answer this?
Can you answer this
Okay,
as well?
I'll
Is that
take this.
right?
Yeah. So the thing is, it is almost immediately after the wrong placement, because you can see it's just the lungs or alveoli are just like a balloon. Once the air has gone out, it will start to collapse. And gradually, when it remains collapsed, fluid starts to build up and other complications can happen. So again, that's why you want to highlight it immediately. Depends on how poorly the collapsed lung is aerated. So it's almost an immediate complication of that. Okay, any other questions? Great. So we don't have any further questions so far. Um, our team has kindly shared a feedback form. Again, thank you everyone for attending. Thank you so much, Numerous. Excellent work. A very good presentation. If you have
Thank
any
you.
questions, you can ask here. We'll keep the chat on for further 4 to 5 minutes. I'm happy to answer. Numerous is here and we're happy to answer. Please do take some time out to fill the form. That's very beneficial. And one thing that I would like to tell our audience is, I know and I understand many of you are trying to enter radiology. So one takeaway from this attendance is you may or may not be able to score portfolio marks for this, but try to keep a record of all the radiology specific teachings that you attend, whether here with us in your departments or elsewhere if you do any courses, because this acts or this behaves as a point towards a commitment to specialty. And you can definitely bring this up in your interviews whenever you're applying. So keep a record, and if you want to submit an evidence, you can do a reflection either on this single teaching or collectively on the teachings that you attend. So make sure it's not just to help you, I mean, for your interviews, it's also to help you improve clinical practice, to learn from delivering and attending teaching. And obviously, we learn from the feedback that you give. Um, and Sadaf has very kindly shared the link to our website. Please make sure you do go on that. There are several resources and we constantly try to improve this. Again, thank you so much. And I will mute myself. We are here. Please do fill in the feedback. Again, I'm highlighting and stressing this because it's very important for us. Thank you so much.